Hi everybody, Mary O'Keefe here from the European Pain Federation EFIC. Today I'm joined by Katja Boersma to give you a teaser of her talk at the 2022 EFIC Congress. So, hi Katja, thanks for agreeing to be interviewed. Do
You're
you
welcome.
want to start by introducing yourself, please?
Yeah, my name is Katja Boersma. I am a professor of psychology at the University of Örebro in Örebro, Sweden. And together with my colleagues, I run a research center called the Center for Health and Medical Psychology, CHAMP. And we do research within the field of health and medical psychology at large, but specifically study psychological mechanisms in the development of chronic pain problems and try to use this knowledge for enhancing clinical assessments, as well as for developing preventive treatments and interventions.
Great. And what will you be talking about at EFIC 2022?
At the EFIC, I will be talking about treatment development that is related to a common comorbidity in chronic pain. That is the comorbidity between chronic pain and emotional disorders, particularly anxiety and depressive disorders.
Great. And in your research, I see the mention of transdiagnostic emotion-focused exposure treatment. So would you mind explaining to us what that is? Because I think you'll be focusing on that in your talk, and in particular, the word transdiagnostic.
Yes. So this is a mouthful, of course, and we sometimes also call this treatment model the hybrid model, just to shorten it down a bit. The term transdiagnostic refers to the fact that patients often suffer several problems, multiple problems, and that theoretically we believe that these different problems may be caused or maintained by underlying processes that are shared. So the term transdiagnostics means that you focus on the shared mechanisms that may explain the co-occurrence of different problems. And our treatment model, so the transdiagnostic emotion-focused exposure treatment, is a hybrid treatment that is based on the fear avoidance model and on exposure treatment for fear of movement, but that broadens the exposure treatment targets to also include patients' comorbid anxiety and depressive problems. So since exposure is difficult for patients and for therapists, the treatment model includes quite an extensive preparatory phase to both analyze patients' problems more broadly, but also to actively engage patients in the treatment and to train skills to regulate negative emotions.
Great. And how might this approach differ to other emotion-focused approaches and also exposure approaches? What would the key differences be to people that are already familiar with some exposure approaches?
Yeah, so there are several treatment models out there that both focus on emotion, or like you say, that focus specifically on exposure, and I do believe that they have probably a great deal in common, more in common than what separates them. What I think they have in common is probably that they all incorporate a modern neuroscience view on pain and psychology, but also on the importance of tackling avoidance. What may be particular about this treatment model is the inclusion of specific therapy methods from dialectical behavior therapy that serve the purpose of engaging the patient in treatment and on preparing the patient for the challenging core of the treatment, that is exposure. And then that the exposure goes beyond the exposure for pain-related fear that is related to movement and activities, but could also include exposure to other targets, such as, for example, for social anxiety or avoidance because of depressive problems.
Great. And so far, do you know if there's a subgroup of chronic pain patients that are more likely to benefit from this approach than others?
Mm-hmm. Well, we developed this treatment actually as a result of ours and our also other suboptimal treatment results with patients who have multiple problems. When it comes to our own research, specifically our work with exposure therapy, where we saw quite a large variance in the treatment results that we could see was related to levels of comorbid distress. So this treatment model is actually specifically developed for the subgroup of patients that have high levels of emotional disorders besides their chronic pain problem.
Okay.
So I think this treatment is likely to benefit this subgroup in particular.
Great. And must you be a specific health professional like a psychologist to deliver this treatment, or can any health professional deliver it, do you think?
Well, I do think you need to have a lot of basic training. I know that there's many physiotherapists around the world that also have this training. So it's not necessarily so that it must be a psychologist, but I think that there is a basic training that is necessary in order to be able to perform this treatment. So I think it presupposes a basic training in cognitive behavior therapy, good knowledge on the psychology of pain and on CBT treatments for chronic pain, and then maybe specifically good knowledge on fear learning and on exposure treatment. And of course, it's also an advantage if you've already previously had training in dialectical behavior therapy because it includes such elements.
Yep. And let's say you have the basic training and you want to be trained in this hybrid approach. How much more training would you need to be competent delivering it to patients, do you think?
Well, that is, of course, a very good question. It's partly an empirical one that we don't know quite the answer to what is necessary, but we are working on an implementation project at this moment where we are developing a treatment manual that we will be giving people access to. And we're also developing now with all of the digital tools available to us, a education platform, including like taped lectures and videos with role playing that we're hoping down the road may be one way in for interested therapists to train themselves in the model.
That's brilliant. And regarding this approach, is the main target pain and disability levels, or is it other targets in the hope that targeting other things might have an effect on pain and disability?
I would say theoretically the target is emotion regulation. And the theoretical idea is that the ability to regulate emotions, negative emotions, and to be able to re-engage in life in a meaningful way will have consequences for disability, pain-related disability, but disability at large, also emotion-related disability. Since it's a comorbid, we're targeting comorbid problems, we're expecting that outcomes that relate to pain as well as emotional disorders are influenced.
Great. And finally, to sell your talk, why do you think people should attend your talk at the Congress?
Yeah. I think people should come to my talk if they are clinically involved with this patient group or within their research, encounter chronic pain patients, or think about and develop treatments for chronic pain patients with high levels of emotional problems. If you would like to know more about theoretical ideas about how we may improve treatments for these patient groups, and also the clinical developments, how we may improve our already quite good, but not good enough treatments for this patient group, who is actually the patient group that we have the least success with helping at this moment.
Great. And any final words? Is there anything you'd like to say that we haven't covered in the questions?
Not anything in particular more than that. I'm looking forward to Dublin 2022, and I hope to meet lots of colleagues from around Europe and the world there, either live, hopefully, or digital.
Hopefully, yeah.
Yes.
That's great. Thanks so much, Katja. That was a great teaser, and I hope to see you at the Congress as well. So for those listening, if you want to join us for our next EFIC Congress in Dublin, Ireland in April 2022, the good news is tickets are now available, and you can get the tickets at www.efic-congress.org to join us in Ireland. So thank you, everybody. Bye.